Okay, sorry, it's taking me a bit. I had to switch 3 computers to find one that would work and then download the PowerPoint and blah, 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 etc. No excuses. Here we are. First time I think I've been asked to present, and I see everybody is not using their screen. That's fine. Let me see before I get started here on Zoom. I wanted to share my screen, but I can't. So one more thing. Here we go. Video. All right. Okay. So what I'm going to talk to you today about is kinematic alignment, the rationale, data, and next steps. Is that more or less what you guys are expecting? Because I wasn't given a lot of direction.
Yeah, I think so.
Okay. All right. So let's see if this works. Let's see if we get started. So my journey started in the summer of 2013. So I had a rotator cuff surgery done. I was not operating for 2 or 3 weeks. And so I went to Sacramento to visit with Steve Howell, whom I knew well from his work on ACL and to bundle ACL work. And he had also just introduced the concept of custom cutting blocks. And along with the custom cutting blocks came this idea of aligning the joints differently than what everybody else is doing. So I went to visit him. And needless to say, things were never quite the same. But I had to go 3 times before I really understood what he was doing. So let's level set a little bit about what that experience was like, and or more interestingly, why it was why it's so difficult for people to accept this concept. Well, the goal of all total knee replacements would be, I think you'd agree, that it is for our patients to forget they ever had a knee replacement, right? That is the ultimate satisfaction from hips. Frequently, they'll say we just forget they even have a hip replacement. That's seldom the case for knees. And we'd like to restore not just normal function, but function that goes back to the pre-arthritic level. Now, what you have to understand is when we invented knee replacements back in the 70s, 80s, when we're starting to put these things in, they failed miserably. They were terrible implants. If people got 5 to 10 years out of it, we were happy. The infection rates were very high. Pulmonary embolysis were normal. We kept people in the hospital for 2 weeks and on suspension. It wasn't a good procedure. So people were very, very concerned with that, and were doing their best to optimize it. And the survivorship of the implants themselves, aseptic loosening, infection, failure, polyethylene wear, were very, very real. And so what they did, the surgeons at the time, would try to create some mechanism by which we could standardize outcomes. And they did it by inventing intramedullary instrumentation, by increasing the implant sizes from 4 total sizes to 7 or 8, changing the configuration of the condyles, etc. But a big, big part of this, of course, was creating this argument around mechanical alignment, which wasn't the only theory at the time, because it was Hungerford at Mayo that was still recommending a 3 degrees of varus cut, because they realized that tibial plateau was not orthogonal to the tibial anatomic axis. But because of the complexity of achieving a 3-degree varus cut and the simplicity of a horizontal cut or orthogonal cut on a tibial axis associated with the femoral shaft and a 60-degree cut, it all sort of worked. And in so doing, they were able to decrease aseptic loosening down by a fair bit, simply by optimizing the process. But that left us with that 20% dissatisfaction rate, that subset of patients who get arthroplasty, the subset of patients who are swollen knees if they do anything that's remotely active, the people who cannot go up and down stairs. And the argument that Howell made was that the knee that you were born with was pretty close to perfect. Now, why is that? Because as the bones grow, as the growth plates extend the length of these articulations, the ligaments, muscles, and tendons around that joint are also growing, and they're matching the needs of that joint exactly. They are perfect. The ACL in every single person is perfect for that patient. It will never work on anybody else. The medial collateral ligament, the lateral collaterals, the hamstring, everything is designed to work for that knee. And you could argue that for 40 or 50 years, for the most part, these work just great. So if the goal is to create a normal feeling knee, the goal really should be to recreate the bony anatomy inside which that envelope of soft tissue lives. And in theory, all we really have to do to achieve that goal, if you think about it, is to replace the cartilage. No need to release any ligaments or PCL or anything else. The trick really is to get that metal to sit exactly where that cartilage used to sit. And if you can do that, the soft tissue envelope around the knee should be pretty darn perfectly set up for that knee. And that I'm emphasizing it because the idea that we're all created the same, they're all created equal, they're all created with the same exact anatomy, orthogonal, 90-degree tibial cut, 6-degree valgus alignment on the femur, is inaccurate. Less than 2% of the population actually is in mechanical alignment. So let's level set that anatomy. We talked a little bit about the native soft tissue envelope. The native soft tissue envelope, the absent injury, wear, congenital deformity, it's perfectly balanced. Every single one of you has a perfectly balanced knee, although each of you has a different knee. It's perfectly balanced. There's no laxity in full extension, not at 10 degrees, but a heel strike at 0 to 10. Your knee at heel strike is solid. You want to have a knee to have 0 play in full extension when you heel strike, when you're running, as is shown in this blue graph here. But as your knee bends, and you need to be able to twist and turn and flex and flex mostly, you need to have an ability for that knee to get out of its own way, in a way to roll back. And that's what you see here at 90 degrees of flexion, the massive amount of flexibility and laxity that there is in the lateral knee. It's quite a bit. It's up to 3 to 4 millimeters of gapping that happens when you flex the knee to 90. And if you don't believe me intuitively, you know it, because when you do a knee arthroscopy, you cannot get a scope in the knee in extension, but you certainly can in flexion, thanks to that gap laterally. The medial side, however, stays tight throughout the arc of motion. A little bit of extra play, but mostly stays tight. And that is what we call the medial pivot. And the rollback that is enabled by this large gap is what enables deep flexion. And the other question is the rotational axis of the knee. Now, you've all been taught that the transepicondral axis is the rotational axis of the knee. In fact, that has been shown not to be true. And if you look at this CT scan down here, there's a CT scan of an actual patient with a 3D rendering. What you imagine is the yellow line is a transepicondral axis. If you try to think about rotating the tibia around that axis, just visually you can see there's a bigger wheel, if you will, here than here. This lateral epicondyle looks smaller than this right one. But if you draw this line here through the actual rotational axis of the knee, the green line, you actually can see that the distance from the axle, think of it as a wheel, to the surface of the condyle, think of it as the wheel, is the same. You don't have two tires of different sizes on your car. Why would you have that in the knee? Turns out that the lateral condyle is slightly larger than the medial by about 1 millimeter. And I just showed that in a 6,000 knee MRIs we just reviewed using machine learning algorithms. It is beyond doubt that the condyles are nearly the same size and that the axis runs through a line more or less where the green one is, which makes a ton of sense. What you see here above is a cylindrical axis. Imagine if you put a cylinder that matched the radius of curvature of the femur, which is circular from about 110 to 10 degrees. This arc here is circular in the subchondral plate. And you put a sphere around that circle and you drive it through to the other side, it'll actually match. And then a line in the side of that cylinder becomes a cylindrical axis of the knee. All right, another point of discussion is that when you do a mechanically aligned knee, you try to place the knee in vertical, like you see on this picture on the left, which is the 1%. 1% of the patient population actually looks like this. Everybody else looks more like this picture to the right, where the tibial shaft is actually at an angle to the floor. It is not vertical. It is not orthogonal. It's not at 90 degrees to the tibial axis as much as we would like. The native knee is not straight up and down. Just when you take a shower next time, look yourself in the mirror, you'll see that your tibia is not vertical. In fact, this joint line orientation angle, which is the difference between the joint line and the floor, has been measured to be parallel to the floor in most patients. So it always stays parallel to the floor, but that's because there is a varus alignment relative to the tibial shaft and relative to the floor. So I just published a series of articles looking at this issue. This tibia is actually on average 4.7 degrees of varus relative to the floor in healthy adults in a varus knee. The valgus knee goes a little bit less, but it's still a pretty decent amount of varus on average. So it actually goes as far as 6 to 7 degrees. All right. So the body, what it does, I'm not sure if you can see me, but it'll keep that joint line parallel to the floor throughout the normal human variance of anatomy because it wants to keep that joint line parallel to the floor, but not by keeping the tibia vertical, right? It moves back and forth along with the tibial shaft. Okay, let's talk more anatomy. Constitutional varus. This idea that varus alignment is normal the idea is varus alignment is normal. It is not a correctable deformity. Drives me nuts. We'll talk about, malalignment of a knee replacement, 3 degrees of varus, or it's a correctable deformity. It is not deformed. You guys are not all deformed at 4 to 5 degrees. Each of your knees is perfectly good. It will last the vast majority of the whole life. And there is this variance. What you see here in this graph above is the variance of the hip knee angle, the angle subtended between the femoral head, the knee, and the knee at the ankle. It's not zero. It just isn't. It averages a little bit less than a little bit more than 1, and it varies a great deal across human anatomy. But what doesn't change, despite this angle between the femur and the tibial shaft, is the joint line remains more or less parallel to the floor. The mechanical axis, that's another interesting question, because if you do have a mechanical axis between the hip and knee and the ankle, it turns out that it isn't static. It's static when you're standing, but when walking or moving, supine, there is a difference, there's a range in this. And the mechanical axis range from 13 degrees of varus to 13 degrees of valgus, as it was taken through an arc of motion using these guides that are placed on the knee, as you can see here, with a sort of a three-dimensional modeling of the joint replacement. As I mentioned earlier, the joint line is native. So the native joint line is parallel neutral to the floor. That allows the body to load the tibia more or less flat in more or less all conditions. Now, these are measurements taken with the patient standing in bipedal stance. And of course, when the foot comes underneath the center rotation of the pelvis during running, this varus comes into even more neutral. So it starts out about 1.5 degrees varus on average, and then at heel strike, it actually comes back to neutral. So if you look at this picture on the left here, this imaging, and I were to restore the patient's normal soft tissue envelope, it's not going to be an orthogonal cut to the tibia. It's going to be at a good 6 or 7 degrees of varus, but when standing, and I put a knee in there, it's going to be nice and parallel to the floor. Hope that you're tracking on that concept. All right, this idea that lateral femoral condyle is hypoplastic. You'll have seen a million x-rays like this, where if you look closely on the lateral view, the femoral condyles look pretty much the same size from here to here, where the arc of the radius of the curvature is constant. And these two turn out to be, as I mentioned earlier, more or less the same size. We looked at nearly 7,000 MRIs from 10 to 60 degrees. And we found that the medial femoral condyle is actually slightly smaller than lateral femoral condyle. Now, why? You've been taught that the lateral femoral condyle is hypoplastic. That is not hypoplasia. That is simply a choice that we're moving the axis of rotation of the condyle away from that condyle into less valgus, into more varus, and in so doing, artificially creating what appears to be a smaller resection of bone, but that's a choice we make by putting those implants, those cutting blocks in that position. So when it comes to anatomy, when it comes to summary of native anatomy, the knee is perfectly balanced. Your native knee, your healthy knee, your human knee is perfectly balanced. An extension at 10 degrees of flexion, 30 degrees of flexion. There's no midflexion stability. All is good. You have your ACL, your PCL, your collaterals. You have this LCL, it doesn't attach to the tibia to allow it to roll back. You have a popliteus tendon that helps it to the check ring to the rollback. You have a lateral meniscus that is not attached to the tibia to allow for that rollback, to allow for that dynamic motion of the lateral plateau, and sorry, the lateral femoral condyle on the lateral tibial plateau with that gap that opens up in flexion. All that is to allow you to flex and twist and kneel. Whereas the medial side, the meniscus, smaller surface area, the meniscus is anchored to the tibia, creates a dish in which the femoral component, the femoral condyle sits, and with a very tight medial collateral ligament that's tight throughout the arc of motion that creates this pivot point for the ligament. And then the way the femur and tibia then interface is driven by the cruciates and powered by the quadriceps and hamstrings. It all makes a ton of sense. The native extension, So the native extension flexion gaps are not symmetric. The native ones are not. The native knee is not a mechanical alignment. The native lateral femoral condyle is not hypoplastic. The rotational axis of the knee is not the transverse axis. The tibia is very seldom vertical when standing. The native jaw line is parallel to the floor regardless of overall alignment. And the hip knee ankle alignment is not a static number to be reproduced throughout the arc of motion. The problem is that all these things are true, but they're all considered to be false in the mechanical alignment world. They're all altered. So kinematic alignment says, okay, let's rethink total knee replacement. Let's take all these things I just showed you. Let's hold them as true. And if that is the case, how would you do a knee replacement? Well, you basically do what's called a resurfacing, like we do a resurfacing on the hip. You just try to put the metal exactly where the cartilage used to be. Obviously, if there's wear, you have to adjust for it, which is where the arc comes in. And if in so doing, if you do that, if you restore the femoral component tibia where it should be, and the implants have some way to at least adjust for the absent ACL, and you maintain the PCL, that's important for KA, you should have a knee that's stable extension, no mid-flexion stability, should work with a medial pivot, a nice lateral gap that opens up in flexion, and central patella tracking, because the patella does track centrally. So how do we plan it? And the coronal plane is, there's those who argue you should never bother with x-rays, but I do use them still. And I put my lines in, and assuming this knee doesn't have a flexion contracture, I can take a look at the subchondral plate and reference that and remove as much bone and cartilage from both sides of the distal femur as I have metal to replace it with. So that's 8 millimeters, and remove the same amount of bone medially and laterally on the tibial side, regardless of where that puts me relative to the tibial shaft. Just restore anatomy. We do this by doing adjusted measured resections, where you take the implant thickness, which is say 9 millimeters or 8 millimeters, which is the average. It's either one or the other in most implants. You take the thickness of the saw, because that takes off a certain amount of bone, which is about 1 millimeter. You adjust for the thickness of the cartilage that usually is present on the lateral and medial femoral condyles and posterior condyles. And I've done a study using machine learning there as well, showing it's often a little bit more than 2 millimeters, but that has been the average that we've been using. And then, of course, the amount of bone you resect. So if it's 2 millimeters of cartilage, 1 millimeter for the saw, the total amount of bone you should be resecting is about 5 millimeters from distal femur. 7 if you're leaving the cartilage on, or the cartilage is retained. So if I resect the same amount of bone from both posterior condyles and from the distal femoral condyle, and I put a component in, what have I done? I've restored the varus valgus of the joint line as defined by the femur, which is, by the way, what defines the joint line, not the tibia. The tibia follows the femur. It's the femur that defines the joint line. And the posterior condylar axis defines the rotation of the femoral component, which is internally rotated relative to what? Relative to the transepicondylar axis. And when you do the same thing in the tibia, and you put the tibial cut in the same slope, the same thickness, and the same varus valgus orientation, now you've restored the plane of the tibia. For those who say, well, yes, but the native tibia on one side is convex and the other side is concave, you're absolutely right. We're not adjusting for everything. yet. And although there are some devices, some implants that try to replicate with polyethylene, that's the same anatomy. So I mentioned earlier this business about the articular cartilage. We want to resect and replace as much cartilage as we take out. Steve Howe did an early study, decided 2 millimeters was the average thickness of the cartilage at the knee. He was close, as close to the 2.3. What's fascinating when I did the study was the variance. It went from 0.95 to 3.73 in healthy knees, as much as 4 millimeters of cartilage in some patients. It's a little bit thinner distally than posterior. The posterior femoral condyles have thicker cartilage. And it tends to be a little thinner in females over males. But overall, I think a 2 millimeter, maybe 2.1 millimeter, 2.5 millimeter thickness number will hold. The tibial cut, as you see here, you're looking to an equal resection on both sides, adjusting bone loss. And the cut needs to be parallel to the femoral cut in full extension with zero laxity. So remember, these two lines, this is where we're in agreement. No matter how you cut these two lines, it should be completely parallel in full extension with the collaterals and the tension, because that's what you'd like to see. It just so happens that this cut is not at 6 degrees, it's whatever degrees that particular patient had. It could be 7, it could be 5, it could be 9, it could be 12. And then there's a corresponding match on the tibial side. The more valgus you have, the more varus you're going to have on this side. Ligaments. The PCL is retained to ensure normal rollback and the correct flexion gap, and there are no releases on the medial collateral ligament. Again, the collateral ligaments are perfectly fine where they are. They don't contract. This is something, I mean, I shouldn't say always, but the severe varus contractures, I do think there's some scarring that happens around the ligaments, but it's been absolutely remarkable how simply removing the osteophytes can restore alignment without any releases. And any of you that have been OR with me have noticed that, we do expose to the medial collateral ligament, but we don't release it. Obviously, there's about 9 millimeters release that happens here where the bone is removed. That's the deep collateral, but the superficial collateral, which is what you see in the shadow here, that is not released pretty much ever. The PCL has to be retained because otherwise you get a mismatch in flexion extension gaps. And when you're doing millimetric resections like this, it does make a difference. So here's a quick video, hopefully this will work, of this process. So this is a patient with 9 degrees of inherent valgus. We remove the cartilage because I've learned that since I don't know exactly how thick the cartilage is, I'll use a subchondral plate as reference. So I'm going to adjust for that, removing all these osteophytes. Then this is using, I think, a different system that I use now, but we make sure that that cutting block is up against the bone. Now this is a Stryker system. And you can see it's right up against the bone on both sides. Now I can resect bone, and I'm going to be looking to see how thick it is, and I'm hoping that this is about a 5 millimeter resection. And we then use a posterior condyles to define the rotation of this tibial cutting, femoral cutting block, and again, checking that I'm removing 8 millimeters of bone with bone plus cartilage, and then I can put the component on. This is what's interesting to me. You can't do this mechanical alignment. I basically haven't done anything to the tibial side. I just resected equal amounts of bone in the femur. If there was a problem with this concept and I put in the trial implant, the knee should be a mess. It should be completely not working. But what you'll find is that, hey, when you actually replace a component and you put the trial in, sorry, I'm going to go back a bit, it works really, really well with no instability and no flexion contractures, all gone. It's phenomenal. So then we'll do this tibial side. I'm looking for some part of tibia that hasn't been worn to help me determine how much to resect. Again, we keep the PCL. And now we got our trials in, and look at that, no instability whatsoever in extension. In flexion, it is a little tighter, tight medially, as you can see here, but laterally it opens up 2 to 3 millimeters. How much? I don't need to know how much. It's exactly whatever that patient requires because that's what they had before. And now here we are again testing the trial and see how snug that is. You see there's no play in mid-flexion. What often happens in mechanical alignment is when you get to that 20, 30 degree gap opening, it opens up a lot, and that turns into instability in flexion. And you can see how well the patella tracks. We internally rotated, quote unquote, the femoral component, but actually the patella tracks perfectly because we've replaced everything where it was. So internal relative to the transcondylar axis or neutral relative to the native anatomic axis. Let's see. Okay, the joint line orientation angle. This is the position of the joint line relative to the floor. And if you look at normal distributions, sorry, this one up here, this normal controls, this is the distribution that happens. If you look at kinematic aligned toe knees, this down here is the distribution of the way the joint line orients to the floor. But when you do conventional or navigated mechanical aligned knees, it throws everybody into valgus. And so if you actually look and see what happens in the long-standing views with any surgeon that actually gets them, and Dr. Hansen does get them, you'll see that frequently the joint line is actually a slight valgus relative to the floor. Not minor slight varus, and here's a slight valgus. From my mechanical perspective, you're better off loading the tibia that's in varus because the forces are more normal to the surface. So this is more or less the same, a similar paper showing the same thing about the joint line obliquity of the kinematic knee arthroplasty, very similar to a normal knee and more neutral than the mechanical. So these are all the mechanicals that go into valgus, and these are the kinematic that are more normally distributed and closer to neutral. There's a question somebody's asked, hey, you put in the tibial joint line into varus, what kind of, is that impacting the ankle? And the answer is the kinematic line TKAs align the ankle joint line closer to those of native ankle because, again, you're restoring normal anatomy. So in long-standing radiographs, kinematic versus mechanical, in bipedal stance, the KA patients had a more normal alignment. The other one that always comes up, and it's like, for years I've been talking about this. Everybody says, oh, your knees will fail in varus. And so I tested this. So we put these tibias in, we plotted them in the Enstrom machine. There's a paper I did before I came here, and we loaded the tibias. One was cut at 5 degrees of valgus, and one was cut in neutral. And we put both tibias in neutral and in valgus, and use this photo elastic material on the outside of these tibias to look and see what impact loading had on the strain in the bone itself. And what we found is that using pressure mapping, we actually had slightly lower loads, but significantly, a lot lower loads when we looked at microstrain. Actually, it was like 30, I want to say 40, 50% less strain in the bone when the tibial cut was made in 5 degrees of valgus, and it was loaded appropriately. And that has to do with the fact that there's a varus thrust in the tibia when walking, and when you adjust for that on the loads applied to the bone, you will actually have a protective effect of the varus tibia. So in fact, the varus tibia may actually be a protective element against loosening. There's another paper we did. This one was done using finite element modeling of kinematic versus mechanical, and we looked at cadaver tibias and we scanned, created a 3D model, and then loaded them. You can see there wasn't a big difference in this virtual model in terms of both the one mesostress and the compressive strains, whether it was neutral kinematic. Bottom line is, whether it's protective or not, it's really not problematic to put the knee into varus. And then this is another paper done by Niki in Japan, looking at kinematic aligned total knee replacements and abduction moments, and what they found, adduction moments, and found that actually the abduction moment was improved when a knee was kinematic aligned versus mechanical aligned. All right, contact pressure. So there's been a big deal, big movement towards putting pressure sensors between the components to see whether or not the knee is truly properly balanced. It turns out that when you don't have sensors available, surgeons' ability to match to match the loads across the medial to tibial plateau are all over the map. And actually, people are not very good at it, even though they think they are. And when you put the gauges in, you can actually tell that the forces on the medial lateral side can vary quite a bit. And what you see in this graph is interesting. This Dr. Medigini, who's not necessarily a kinematic alignment, he's not that favorable to the concept, put these sensors in and found that mechanically aligned total knee replacements where the pressure force on the medial side way higher than anything you would see in the kinematic aligned knees. And the lateral force, of course, in kinematic alignment is super low because you have these gaps. And people who tried to create these matching gaps had much higher forces in the lateral compartment. And there are other papers showing this. The contact pressures in vitro are similar in kinematic aligned knees to kinematic to normal knees, to healthy knees. This paper we just talked about showing lower contact pressures in vivo, and this is a paper by McDessie from this past year. That not only contact pressures lower with the knees were kinematic aligned, they're more likely to be optimally balanced without any further recuts or soft tissue releases without right off the bat at the very first cut. All right, concerns about medial compartment overloads. These are some papers looking at whether or not that's a thing. Intraoperative force is equal to those considered to be in range, even for patients with greater than 3 degrees of varus line vertebral shaft. That's the first paper. Second paper, similar migration patterns using RSA. They put the beads into the implants and shows that actually kinematic aligned knees do not migrate through bone or cement any more than standard implants do. There's less dynamic edge loading. This is Neil Bill, who's working in Colorado and doing fluoroscopic studies showing that the knee tracks better inside the polyethylene or around the polyethylene and does less dynamic edge loading. I showed there's this paradoxically decreased tibial cortical strain, and at 10 years, Howell published in 2019, and now it's 15 years, that basically there's no loosening of tibial components. These are now being done around the world, and they're not failing, folks. They're just not. So this was the biggest concern. So what if it's shown higher loads? What if rather than having lower loads, kinematic aligned knees, the loads would actually be higher? Well, I would argue that today's implants are not yesterday's implants. Devices that I put in as a resident were useless. They were terrible. They failed miserably. The locking mechanism, the backside wear, the polyethylene was sterilizing air. The implants had sharp edges. They weren't that smooth. I mean, like, it's like saying that you can't go at 75 miles an hour around a corner because your car can't handle it. And the car on the left could not handle it. The car on the right can do it without a driver. So things have changed. Our components can take better loads, higher loads. So even if for some reason somebody were to show that there's higher loads in the knee, in Valgus alignment, let's say that they can handle, the implants can handle it. So what are the clinical results? So far, the results have been quite encouraging, except that loosening is simply not a problem. This is a paper by Cordial, 877 kinematic aligned total knees, where they've been followed 38 months. Survivorship 97%. Short-term follow-up, yes, agreed. Lower one below, 2017 total knees, follow-up at 6.3 years, 97.5% survivorship. But let's just say that they're simply not failing at the massive rate that many expected to see happen with this varus tibial cut. And we'll talk, if we have time, as to why a varus cut in tibia is perfectly okay in K, but absolutely nothing to be should be avoided at all costs in mechanical alignment. It's not the same thing. Okay, this is another retrospective study, 661 patients. Kinematic aligned knee is 3 times more likely than mechanical to report a normal knee. 78 patients with kinematic alignment following prior mechanical. This is a forgotten joint score, 15 points higher for kinematic alignment. And the robotic tip total knee, no difference to mechanical alignment in gait or COOS, but only a small study of 15 patients. What you will find is, so these are the no difference papers, 71 knees, 99 knees, all excellent results. And the 2 papers that showed a difference. This is a PSI versus manual, and the PSI was KA, and they felt that the manual actually was slightly better. No, sorry, PSI was better than manual, and it was a KA. And this 120 patients, PSI versus manual, better Womack outcome, Dawson 2014. This is restricted kinematic alignment, sorry, not robotic. So there's a school of thought that says, oh, it's all good and fair. We agree with that. However, you really just can't go past 3 degrees of varus in tibia, and adjust whatever you have to adjust to make it all work. Just don't go past 3 degrees. So that's called a restricted Ka. Some people say 5 degrees. The FDA hasn't fully come down one way or the other, but for a long time, the concern was that anything over 3 degrees would not be accepted. Okay, so difficult to execute accurately. This requires robotics and navigation, in my opinion, to get it right, or to be a very good balancer, because when you shoot for 3, but it was really 5, you've got to play with it somehow to make it work. The clinical outcomes for restricted kinematic alignment is essentially no difference from mechanical alignment, but nonetheless, it's really not any worse. There have been some attempts at doing meta-analyses. This guy, Sepier, is actually applying for fellowship with us. There's a systematic review at 2-year follow-up kinematic alignment. It was comparable or superior clinical outcomes for Ka. Overall, limb alignment is similar, because when you put most people in Ka, they wind up within 1 or 2 degrees of mechanical. It's just not on mechanical. They almost always had a joint that was parallel to the floor, and much more frequently than mechanical. And the complication rate really was no difference. No difference in infection rate, certainly no difference in revision rate. So of these, 6 have been published. The methodologies all were somewhat better, but you can come back to this idea that basically the patient-reported outcome scores are generally better or the same. Function is certainly better. Complication is same. Problems are similar. This is the world's literature on poor outcomes following kinematically aligned TKA. Right? There really isn't a single paper that's reported that it's worse, out of several hundred. Now, if we have time, we have 10 more minutes. I want to talk to you a little bit about this. I don't have good slides for this, but this is a total knee that was put in mechanical alignment and failed in varus. Inevitably, this is the slide they show me when they say your knees will fail if you put them in kinematic alignment. If you put them in varus, they'll do even worse. I put this in neutral. The problem you have here, and I don't think I have a slide for it. No, let me go back. Is that when you do mechanical alignment and you decide to take a tibia out of varus and put it in neutral, that means you have to take the femur, which was in valgus, and put it in more varus, because otherwise the 2 lines, in extension, it won't be balanced. And then when you go in flexion, you have this tibia that was in varus. You've now taken this femoral component and done what to it? You put an external rotation relative to where it was before. You put an external rotation relative to what it was before, and you've accidentally put the tibia in varus. Now that lateral flexion gap just got really tight. The medial side got lax. Now we learned before that in the native knee, it's the opposite. The medial side is snug throughout the arc of motion, lateral side is lax. So from a pressure perspective, the amount of loads you're now placing on that lateral knee go through the roof. That knee won't bend past 70, 80 degrees. Or if it does, it goes to 110, 115. The pressures are very high, as you saw in the Minigini paper a little while ago. Those loads are applied in flexion and the posterior tibia, which starts to rock. It then loosens. Now, most of the time, we're loading our knees in extension, and 60% of the load goes on the medial side. If you have a loose tibial tray that's been loaded on the medial side, it's going to fail in varus. So a poorly done mechanically aligned knee will fail in varus, but not because the tibia was placed in varus originally, it's because it wasn't placed in enough varus and the femoral component was externally rotated. So don't make a mistake. If you're going to do mechanical alignment, do it very well. We have some people do a very, very good job here with mechanical alignment. I did thousands of them, but you have to understand that each system has to be done according to the way it's intended to be done if you're going to expect the published results. A couple of problems of outcomes. weight bearing axial alignment views are prone to error caused by hip rotation and flexion tractors. Problems of massive ceiling effects. What you have to understand is that, for example, the knee society score, 53% ceiling effect. Oxford knee score, 33%. Womack, 30% on pain, 10% on function. The Womack on function is pretty good. Womack function is the only one that shows a difference consistently with kinematic alignment scoring higher. Coos, not as bad, but still 20% variance. And a forgotten joint score, which is supposed to have been designed in a way to not have ceiling effects, actually still has it. And also, there's much variation in definition of what's kinematic alignment. This is one of the most varus knees I ever did. It's 13 degrees of varus. I put that tibia in 13 degrees of varus, and that post-op x-ray gave my fellow a heart attack. But look at the standing x-ray. That tibial plateau is perfectly parallel to the floor, and it's still slightly valgus. The other knee that was done by somebody else put in neutral mechanical alignment, all that stuff. Look at the thickness of the poly insert they had to use, because they had to do massive releases medially to make up for the fact that they're taking out this trapezoidal piece of bone. All right. And then how happy is that patient? That's a very unhappy patient. They hated the left knee. This is the right knee at 1 month post-op, the one that we did with that really crazy looking tibia. And she is just loving that knee. And she could not be happier. So yeah, so my colleagues may not like that x-ray, but the clinical results speak for themselves. Every time I put a knee in appropriate in any alignment, I get those results. And you can do it with any kind of random deformity. These are not easy knees to take care of, but I did these without intramedullary guides, using only the joint line as my reference point. And the other thing I've done, a little bit weird, is I take a knee like this. So you look, this knee here is put in mechanical alignment, was very, very stiff, very unhappy patient. Notice the tibial joint line is in valgus. It's at 2 degrees of valgus to be exact, and the femur is only in 5 degrees of valgus. On the other side, he has 7 degrees of valgus and 5 degrees of varus. So he's actually 7 degrees off his normal anatomy here. So what do? We revise him back into that weirdness. And sure enough, look at this x-ray. It looks kind of weird to you, but I can tell you it was a very, very stable knee. Couldn't be happier. He had 60 or 60 degrees of range of motion prior to surgery, and now he's close to 120. And just couldn't be happier. When he stands, his knee looks straight. This is more random, severe post-traumatic deformity. The joint line on the tibia is messed up. There's lots of bone loss. I agree. But the femur is where more or less it used to be. So by keying off the femur and working on the tibia, we're able to get this implant combination in, a little bit overhang laterally, but also a very happy patient. And it should look, even though this x-ray looks weird, his leg is straight. So what K is not, as I mentioned, a varus tibial cut is not kinematic alignment. Just putting the tibia in a little bit of varus is not a kinematically aligned knee. You have to externally rotate the femur, or at least rotate it back to posterior collar axis to get to avoid posterior conflict. And you don't want to get into the situation where you put in these knees in incorrectly for all components. So what next? Thinking unbounded by the limitation of the past will be critical to success in the future. If there's anything I want the residents to get from working with me, because I do this a lot, is to challenge assumptions. Everything we were taught, I was taught for the most part, is no longer true or is only partially true. You're learning constantly. Don't let things limit how you think. Kinematic alignment today is a cruciate retaining technique. There's really no data for posterior stabilized implants put in this position, so we'll have to see if anybody does that work to figure out how to do it. There's something called functional alignment or limited kinematic alignment. These are variances on the theme. There may be a point at which there is such a thing as too much valgus, too much varus on tibia or a femur, and that may be something that we have to define. You're seeing some medial pivot total knee designs coming up. They did not do well in mechanical alignment as a rule. They're doing very, very well in the KA space. Outcome measures, problems are much, much too blunt. You can't tell the difference of a patient's golfing with or without a cart. And so I think the future and the work I'm doing in research is on sensors of biometrics. That's why I do all this work with these kinds of devices and using navigation and robotics, because I really want to see whether or not we can use sensors to get more objective outcomes that actually document the improvement of these surgical techniques as we put into place. So I'm going to not go over my research today, but if any of you are interested in this, is using large data sets, machine learning algorithms, but the end point of all this is to define and create sensor-derived outcome measures that we can use to track patient wellness, recovery after surgery, in a way that's much more accurate than the RAND or VR12 or WHOIS or the VAS scores, to track patients and help us triage care to them. We've learned a ton about sensors in the lab. Absolute data measures are not as predictive as longitudinal data. Sensor accuracy is not as important as this consistency. We're better off with a consistent data point than an accurate one. The more data you have, the better. But interestingly enough, by about 2 weeks, we can track, we can predict how well people will do at 6 weeks, which is pretty cool. Now working with Google, we have a large grant to see if we can do Sensors 2.0, and some of the smartest and brightest people in machine learning are working on this project. Our goal is to test the idea, correlate the sensor output with longitudinal postoperative patient outcomes, then do multi-center, multinational studies, and share our data publicly so as many people as possible can do their best to improve the algorithm. I'm also starting a society called the Personalized Arthroplasty Society. It's an international society dedicated to the education, study, and promotion of kinematic alignment and all its subdivisions. But the point is that we shouldn't all be doing the same operation. Every patient, we should personalize those results. With that, I think I'm right on time. My couple minutes over. Hope that was what you guys are expecting, and if nothing else, thought-provoking.